there is basically three levels of diabetes. I mean, there is the one that you can treat by diet. The second, where you have to take oral hypoglycemic medication. And the third one, when you have to receive insulin. And of course, you have also to make the difference between diabetes 1 and diabetes 2. Now, in general, diabetes, mainly the one which is depending on insulin, is bad for the cardiovascular system. That's clear. You have more disease at the early stage, etc., etc. And in many, many studies and registries, it has been demonstrated that bypass surgery is somewhat superior in terms of durable effect, mainly MACE, revascularization, myocardial infarction, in the medium and long term, let's say up to 5 years. The novelty of what we have presented is that if you go up to 10 years, okay, which is quite difficult to do because it's a long process, 10 years follow-up. And what is important in 10 years follow-up is basically the all-cause mortality. The all-cause mortality is an unbiased assessment of what's happening with the patient. And we were surprised that in the syntaxis, 10 years follow-up of the syntax study, we were surprised that the curve diverged for the first 5 years. And then globally, if you take all the diabetic patients, the curve converged after 10 years. So there is a divergence and a convergence. And of course, at the end of the day, everybody died. But nevertheless, we were impressed by that phenomenon. And it's clear that there is still some difference in the insulino-dependent patient, but that difference is no longer significant. Now, why surgery will be for the first 5 years highly favorable and less after that, we believe it's the fate of the saphenous vein graft, because these type of conduit get worn out and there is an attrition around 5, 6, 7 years, sorry. And that might explain the alteration, the long term of the prognosis of the bypass surgery. So that's the new piece of information. What is very important for the practitioner and for the trialist is that we always look at what the community of epidemiologists call average treatment effect. What is the average treatment effect? It's the fact that two Kaplan-Meier curves diverge and you end up with a difference of 5%, 10%, whatever. And then are you going to take a decision only on that difference, on the average difference between two groups? That's the way we have been practicing and interpreting trials for a long, long time. But as a matter of fact, you know that in your population, the population that you have randomized, there are patients who are going to benefit from the treatment, who are patients who will have an equivocal result. You can go both ways. And there will be patients that will be harmed by the treatment. And that's also true with percutaneous treatment and bypass surgery. So over the last 10 years, we have tried to construct a model where we can identify in that population who is going to benefit for the bypass surgery and who is going to benefit from the percutaneous treatment, and vice versa, who is going to be harmed by the percutaneous treatment, who is going to be harmed by bypass surgery. And we started a few years ago in the Lancet in 2013 with the syntax score 2, which is a mixing of anatomic character and comorbidity. And then in 2020, we have redeveloped the program, and that's called the syntax score 2020. And with that score, you can identify, even in the diabetic patient, you can identify patient who will benefit from surgery or will benefit from PCI. That's a personalized care, personalized prediction. And because the prediction is pretty good, yeah, you have to respect that, because there is a very good relationship between the predicted mortality and the observed mortality. So that's what we are doing now in the selection criteria. We are applying the syntax score 2020. I think that we have just published in the European Heart Journal the 5 years result of the syntax 2, yeah, which is a single arm trial with propensity comparison to the whole syntax done with the Taxus stent. So it's really old-fashioned technology, but it's still, the predictions still work quite well. That's point number one. And point number two, we have in the syntax 2 trial clearly made first the right selection using the syntax 2 selection. Okay, that patient may go to PCI because the mortality at 5 years will be, or 10 years will be okay. That's the first point. The second point is minor, but you can use already massive statin before the procedure. The point number 3, you have to select the vessel based on physiology, QFR, IFR, FFR. And you have to make your planning according to the result of QFR, FFR. So if you have 3 lesions, you don't have to stand all 3 lesions. You have to stand maybe the first one, maybe the last one, maybe a combination of 2-1 based on the residual IFR of QFR, which should be above 0.9. 3, you have to use ultra-thin stent. There's no problem. That's clear. Now, there have been 3 of them on the market, Serruys from Biotronics, the My stent, which was also an ultra-thin stent, and more recently, the Supraflex Cruise, which is all 3 60 micron, yeah? And the Supraflex Cruise is 60 micron on all the dimensions. After the implantation of the stent, it's good to do, at least in multivessel disease, an IVUS or an OCT to show that your implantation is perfect. And then what is very important is to have what we call OMT, optimal medical treatment, okay? Eventually aspirin, statin, very, very important, very, very important, and medication against hypertension, and of course, treatment of diabetes. Because in the syntax 1 trial, after 10 years, the curves are still diverging between the patient who received the optimal medical treatment and the one who don't receive. So that's the recipe, ultra-thin stent. So far, there have been 2 meta-analyses. One is published in European Heart Journal, showing that really the ultra-thin stent have an edge in almost everything, thrombose, MI, revascularization. The most difficult is always all-cause mortality, but the more you do of these meta-analyses, the bigger the numbers, and you are able to demonstrate that the ultra-thin is the way to go, yeah?